Welcome aboard! If you're watching this video, then let me be the first to say, congratulations! You've recently been promoted to 4th year PT and this is your first official stroke assessment training.
Can I assess a stroke patient now?
Oh no, you've got a lot to learn before you're ready to assess a stroke patient. The neurological assessment. The neurological assessment requires for the PT to test the functions of the following: the cerebrum, the cerebellum, the cranial nerves, sensation, and reflexes. Sounds like a lot of hoopla! Sounds like a lot of hoopla! 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 Sounds like a lot of hoopla to assess a stroke patient, right? Assessing the function of the cerebrum. The patient's mental status, communication skills, body scheme, and determining whether or not the patient has apraxia are the 4 key components of cerebrum examination. One of the components of assessing mental status is to determine the level of consciousness of the patient. This may be determined all throughout the patient examination. The patient may present as either alert, lethargic or somnolent, obtunded, stuporous, or in a coma or vegetative state.
So, what's the difference between a person in a vegetative state and a person in a coma?
Well, a person in a vegetative state can still open their eyes and still has a sleep-wake cycle, meaning they still know when the morning and evening starts. Compared to a person in a coma, they really have no response at all to any form of stimulation.
Ah, cool. So can I assess a stroke patient now?
No. The other components of the mental status is administered through asking of questions to be able to determine further the status of the patient's cognition. An example of those questions are the following.
Alam niyo po ba kung ano yung pangalan niyo?
Tope Cruz?
Alam niyo po ba kung nasan kayo ngayon?
In the classroom?
Alam niyo po ba kung anong araw ngayon?
March 21, 2017. Great job, Mr. Cruz!
So, may bibigay akong set ng letters, words, o kaya numbers, ha? So, repeat after me. Dog, A, 10. Sige nga.
Dog, A, 10.
So, ano yung kinain mo kaninang umaga for breakfast?
Sobrang sarap na crispy pata.
So, sino yung presidente no 10 years old ka?
Si Erap ata? The attention span of the patient is also tested and can be done together with the testing of the presence or absence of apraxia. The communication skills of a patient is tested as well to determine the presence of aphasia. Aphasia is the loss of speech, which can either be motor in nature called Broca's aphasia.
Is it a boy? Is it landing?
For you to do
Sensory in nature called Wernicke's aphasia.
First thing I'd like for you to do is stick out your tongue. Stick your tongue? Great. Show me how you would kiss. Show me how you love to kiss me. There you go.
Or both, called
Show me
global
how you
aphasia.
stick on a straw.
Now this is Eliza. She is now checking for the presence of apraxia on Mr. Badar. Let's see how she applies all of what we just learned to her patient.
Gusto ko po mag-gawin kayo ng clock. Alam ko po ano yung clock.
There are 2 types of apraxia. ideomotor, wherein the patient is able to do the activity but cannot follow instructions, and ideational, wherein the patient cannot do both the activity and follow instructions. As we can see here, Mr. Badar was able to both follow the instructions and the activity given to him. Good job, Mr. Badar! In terms of body scheme, there are 9 subtests that can be administered, which each addresses different deficits in the patient's perception. With right and left discrimination, the patient is given 2 objects to hold with both hands, and the PT will ask the patient to give the object on whichever hand. If the patient gives the object using the wrong side, this will connote a negative right or left discrimination. Somatognosia tests the perception of the patient in terms of the relationship of one body part to another. This is done by asking the patient to identify a part of their body. Depth perception is tested through putting 2 objects on 2 different depths or heights and asking the patient.
Pwede niyo po bang ituro sa akin kung saan po yung mas malalim?
It is best to use easily visible objects placed on a high table and on the floor. Over here, PT Bryson is asking his patient to get the object beside of the right highlighter and later on the left of the blue highlighter. As you were able to observe, Mr. Badar was not able to get the right object. This test examines the patient's ability to perceive an object in space called spatial relations. In figure ground discrimination, 2 similarly colored surfaces were presented to the patient. As the PT puts the smaller surface on top of the other, some patients will not be able to recognize the location of the smaller surface and start to perceive the 2 surfaces as now one. But when separated once more, they start to realize the difference in size again. In some cases, vertical orientation is tested by asking the patient to walk in a straight line and seeing if they are able to maintain the straight walk. But since that is more dangerous, in this case, Bryson tested vertical orientation by asking the patient to try to make a bottle of water stand up on the table. One of the more dangerous tests under body scheme is the topographic disorientation test, wherein the patient who presents positive have no sense of direction and should not be left unsupervised. To test if the patient neglects the affected side of the body, the PT may administer reaching activities in different directions or make the patient do functional activities that involve grasping and reaching, like drinking a glass of water. Some patients, instead of neglect, deny that there is a problem with the affected side of the body. Usually, the patient will ask about the affected side and listen to the response of the patient. As you can see here, Mr. Badar presents with anosognosia, or the denial of the bad side. Assessing the cranial nerves. Everyone has 12 cranial nerves, which has different functions and jobs to do in our body. Starting from the olfactory nerve, it is tested by letting the patient smell common aromatic and non-irritating odors like coffee or garlic without the patient seeing the substance. The visual acuity, visual fields, and eye reflexes are the responsibility of the optic nerve. Visual acuity is tested using the Snellen's chart, where the patient stands 20 meters away from the chart and reads the letters on it aloud.
Sure, I'm going to read off line number 8.
Okay.
D, E, F, G, O, T, E, C.
Visual field is checked through the confrontation test, wherein the peripheral view of the patient is being tested by asking the patient to tell you where he or she stops seeing your fingers. The reflex of the eye is tested through the pupillary eye reflex by flashing a pen light on one of the patient's eye and checking for the constriction of the pupils. The oculomotor, trochlear, and abducens nerve are responsible for eye movement and is tested through letting the patient move his or her eye in all directions. The oculomotor nerve innervates the inferior obliques, medial rectus, and superior rectus muscles of the eye. while the lateral rectus and superior oblique eye muscles are innervated by the abducens and trochlear nerve respectively. The trigeminal nerve is responsible for the closing of the jaw through innervating the muscles of mastication. Strength of the muscles of mastication is tested and it is graded as poor functional, weak functional, and good functional. Here, it is the masseter and the temporalis muscles that are being palpated. Superficial sensation of the face, like light touch, using a cotton, pain, using the end point of a reflex hammer. Temperature, using the test tubes with hot and cold water. And pressure, using a thumb, is also tested under the cranial nerve. The facial nerve is the main nerve that innervates the muscles of facial expression and is tested through doing the following facial expressions: happy face, sad face, frown face, kissy face, shock face, close eyes, cheek puff, nose wrinkle, and Squidward's default face. Eye closing is also tested by asking the patient to close their eyes as the PT manually opens them. Lastly, since the 7th cranial nerve also innervates anterior 2/3 of the tongue, the patient can be asked to identify different taste stimuli like salt, coffee, or candy. Sipping of water in between is a must, so don't forget! Hearing for the vestibulocochlear nerve is tested by placing a ticking clock just in front of the patient's ear and then moving it away, asking the patient to state where he or she stops hearing the ticking. The Weber's test is conducted by placing an already vibrating tuning fork on top of the patient's head and is asked where the sound is heard more. If the sound is heard more on the unaffected side, then the patient has sensory neural hearing. But if the sound was heard on the affected side, then the sound vibrated on the bone, making his hearing conductive. For the Rhines test, the same tuning fork is placed on 2 places while vibrating: on the mastoid process and just in front of the ear. If the sound is heard more when it was placed on the bone, then sound uses bone conduction, and if it was heard more in space, then the sound uses air conduction. For the glossopharyngeal and vagus nerve, the patient's gag reflex, swallowing, and speaking are tested. A tongue depressor is used in order to elicit the gag reflex. If there was a gag reflex, then there is no affectation to these nerves. Under this, we also check for the jaw jerk reflex, wherein the jaw will deviate contralateral to where you tap the mentalis muscle. The accessory nerve is tested through shrugging of the shoulders and laterally flexing neck with rotation against resistance. This tests the SCM located at your neck and trapezius muscle located on your upper, middle, and lower back. Last but not the least, the hypoglossal nerve is tested through checking for tongue deviation, atrophy, or tremor. The sensory assessment. There are 3 classifications of sensation: superficial, deep, and combined. Under superficial sensation is light touch, deep pressure, temperature, and pain, which are all assessed the same way as the superficial sensation of the face were assessed. With deep sensation, proprioception, kinesthesia, and vibration sense are tested. To differentiate proprioception from kinesthesia, proprioception is the position of the limb in space, while kinesthesia is the direction of the movement of the limb. For proprioception, you ask the patient the position the limb is in currently. And for kinesthesia, you ask the patient in what direction is your limb moving. For vibratory sense, the PT puts a vibrating tuning fork on top of a bony prominence and asks the patient what they feel. The patient should be able to feel a vibration on the bony prominence. For combined cortical sensation, we start with 2-point discrimination, wherein the patient is asked to identify when he or she felt last that there are two surfaces touching his extremity. As for stereognosis, the patient will be given different objects and with their eyes closed, will ask the patient to identify the object placed on their hand. With graphesthesia, it is tested by asking the patient to identify the letter, number, or shape being drawn on the patient's limb by the PT. Barognosis tests the patient's ability to distinguish weight difference between two similar objects. In this case, Wesley is being asked which one is the heavier jug while his eyes are closed. Tactile localization tests the patient's ability to pinpoint where the pinprick was done on his or her limb. It is suggested that the PT uses a blunt object to facilitate the test and should not hurt the patient to the point of scarring and bleeding. To test texture recognition, the patient is given different surfaces, in this case one rough and one smooth, and is asked to describe the type of texture or surface he or she feels while their eyes are closed. Double simultaneous stimulation tests the patient's ability to perceive simultaneous touch stimuli. At first, the PT will simultaneously touch identical locations on opposite sides of the body, and then proximally and distally on opposite sides of the body, and then proximal and distal locations on the same side of the body. It is important to note for extinction phenomenon, which is used to describe a situation in which only the proximal stimulus is perceived, with extinction of the distal. It should be taken note that if the 2-point discrimination and stereognosis tests are intact, it will be unnecessary to do the other tests. Assessing the function of the cerebellum. There are two types of tests under the cerebellum assessment: the non-equilibrium tests for the coordination of the patient, while the equilibrium tests for the balance of the patient. There are many tests under coordination assessment that can be done to the patient, and these are some of the tests that can be administered. The alternate nose-to-finger test is done by asking the patient to alternately touch his nose and the PT's finger. The finger-to-finger test is administered by asking the patient to abduct their shoulders to 90 degrees and bring both hands to the midline and approximate both index fingers. Testing finger opposition, the patient is asked to touch the tip of the thumb with each finger in sequence. For the mass grasp test, the patient is tasked to alternately open and close their fist. For the pronation and supination test, the patient is asked to alternately pronate and supinate while the forearm is at 90 degrees of flexion. The rebound test is administered by positioning the patient's arm at 90 degrees of elbow flexion and is asked to resist the force the PT will apply. This force will be suddenly released, and the normal response is for the forearm to rebound once the force is removed. With the tapping of the hands and the feet, patient is asked to tap the hands on the knees and then after his feet while sitting and while his heel remains in contact with the floor. The pointing and pass pointing test is tested through asking the patient to flex the shoulder and fully extend the elbow. The PT and patient is opposite each other and both of them should assume this position. The patient is then asked to fully flex his or her shoulders and then return to the horizontal position such that the index fingers will again approximate. For the alternate heel to knee and heel to toe test, the patient will be asked to position himself in supine while he is asked to touch the knee and big toe alternately with the heel of the other extremity. For the toe to examiner's finger test, the patient is positioned in supine while he is instructed to touch the PT's finger with his or her big toe. The heel to shin test asks the patient in supine to slide up and down his shin on the opposite lower X. Another test is administered by drawing a circle in space with either the upper or lower extremity. A fixation or position holding test is tested by asking the patient to hold the arms or knees horizontally. On the contrary, the equilibrium test assesses different functional movements like standing, walking, step over or around obstacles, stair climbing, and jumping jacks. It should be noted that when choosing for the tests that will be done for both non-equilibrium and equilibrium, not all the tests will be administered. Only 2 non-equilibrium and 1 equilibrium tests should be done. Assessment of reflexes. Because stroke is an affectation of the central nervous system, the different reflexes must be tested to see if any pathologic, primitive, or associated reflexes are present, or if the balance reactions are still intact. The DTRs are needed to be assessed in order to establish if the patient is hyperreflexive, hyporeflexive, areflexive, or normoflexive. Some of the areas where DTRs are done are at the triceps tendon, biceps tendon, quadriceps tendon, and Achilles tendon. As mentioned a while ago, there are 4 other reflexes that are tested under this assessment, starting with the pathologic reflexes. The Babinski sign, the Oppenheim test, the Chaddock test, and the Gordon test. All these tests are done to check for the fanning of the toes. A positive Hoffman's will elicit a flexion of the distal phalanx of the thumb and index or middle finger. In some cases, the primitive reflexes comes back and present when elicited. Some of the primitive reflexes that can present are ATNR, STNR, and STLR. Some more reflexes that can present are called associated reactions, which are the following. Sterling's, where its lower X counterpart is called the Ramis test. Marifois, wherein the passive flexion of the toes will result to a mass flexion of the whole lower X. Sockes, wherein the passive flexion of the shoulder results to the extension of the wrist and fingers. And homolateral synkinesis, where resisted flexion of the upper X will result in the flexion of the lower X. The PT must also check if the patient's balance reactions, like the protective extension and writing reactions, are still intact.
cool.
Now you know the secrets to assessing a stroke patient.
So can I assess?
But wait, there's more.
What is it?
Do you really want to know? The secret to assessing a stroke patient is